people are getting a little bit tired, but we would like to just maybe invite Steve Mutsaers and Jim Lloyd up for maybe 5 minutes or thereabouts to just give us their thoughts and their summaries about what they've heard about today, and maybe some follow-up suggestions from the audience if that's appropriate. And then we'll wrap up at sort of in 5 minutes and then have you come back from lunch in about an hour. So, Steve, do you want to start with the first 4 talks, and then Jim's going to cover the final 4?
Yep. So first of all, I apologise for the poor four first speakers who've got me to summarise their talks. It's very hard to summarise so much excellent work in a few minutes, particularly David Warburton's. It'll take me 30 minutes just to summarise his 20-minute talk. I think one of the things that stood out to me early on is I think there's going to be a fight in the lunchroom in a few minutes between David and Cecilia Sanchez. David believes that IPF is a pediatric disease, whereas Cecilia mentioned it's a disease of the aged. I think the key there is that we do see it in the aged, of course, predominantly, but like a lot of different diseases, predisposition is probably very early on, and I think what's very important is that we can identify these people as early as possible so that we can start intervening either by preventing or at least by treating. Now, some of the key points from David's talk, I mean, he talked about the importance of TGF-beta, both in development and in disease, and I think what the key here is it's all about the amount and the timing. And there's many mechanisms that TGF-beta can utilize. Immune regulation, of course, is a very important one. I think, as we all know, TGF-beta is a very important molecule, but also a very complicated molecule. And so trying to manipulate TGF-beta levels is going to be very difficult, but very important. I'm going to concentrate just a little bit on his studies with the amniotic fluid stem cell therapy. We found out that stem cell therapy actually is a physiological process, and where a lot of mothers believe they're going to get rid of their kids at 20 or 30, I think what they're finding is that they're going to be, parts of them are always going to be with them, I think particularly if they're generation Y stem cells. He used a bleomycin model that we all use, of course, to look at whether you can attenuate fibrosis by giving stem cell therapy. He used the amniotic fluid stem cells and showed that he can actually downregulate the amount of fibrosis, probably through a reduction of inflammation and an increase in repair, although the mechanisms are still a lot to be elucidated. One of the key issues that he brought up was, of course, the role of CCL2. He found that the stem cells were recruited to the lung by CCL2, but of course you don't want too much recruitment going on for too long, so these cells also had the ability to downregulate CCL2 after they got there, possibly through mechanisms involving MMP9 cleaving the CCL2 molecule, creating this dominant negative type effect. So then we went on to a talk by Gyong Yu, who looked at microRNA expression, showed that microRNA are upregulated or downregulated in IPF. There's a variety of up and down regulation. I think 90-odd were up and 90-odd down-regulated. And that occurs in a lot of different disease processes. The key is to identify which ones are important or which combinations are important. He looked specifically at MER29. He showed that it was downregulated in IPF patients and also in the bleomycin model, a nice correlation. And that if you treated these animals with MER29B, which is one of the family of 29s, using a MER29 mimic, you could upregulate the amount of microRNA in mouse tissue, and that would reduce fibrosis. And he measured that in the bleomycin model, and he looked at both lung hype levels and histology. And he thought that this could be through regulation of IGF-1, but we also know that there's a lot of targets for the different microRNAs, so I think a lot more work needs to be done to identify how it's working. Then I'm just going to talk about 2 talks together from Cecilia Sanchez and Avinath Patel, who really complemented each other's work, looking at autophagy in IPF. I think it's very important to know that autophagy is a very important area of study at the moment. There's a lot of work being done, particularly in cancer, but it's very much environment and cell regulated or specific. So in cancer cells, for example, autophagy can protect from apoptosis, or it can induce apoptosis. And I have no doubt the same thing would be happening in other diseases such as IPF. And as I said, it's all dependent on the environment and the cell type. What both looked at was the effects of TGF-beta on autophagy, and they found that TGF-beta actually inhibits autophagy in fibroblasts and myofibroblasts. This does appear to be dose dependent, and there's always that question of what you see in vitro needs to be taken and looked at in vivo. So that's a very important thing to look at. But the mechanisms of TGF-beta regulation of autophagy in IPF is very unclear. There are a lot of different mechanisms that can be utilized, and two that were pointed out in particular were mTOR and TIGAR. There are a lot of different ones. So exactly how it's regulating, it's unknown. But what the key was is that if you correct autophagy, that may be a very good clinical approach. I mean, they showed both in vitro studies and in vivo studies that if you upregulate autophagy, you could actually reduce fibrosis, you could inhibit myofibroblast differentiation and collagen production, and increase collagen degradation as well. So overall, these studies would suggest that autophagy is good. Well, maybe.
So on your program, you'll see that Naftali Kaminski was scheduled to give this summary. I am not Naftali Kaminski. I wish I were. Disappointing for you that I'm not. But I was struck by the excellent 4 talks at the last part of the session, that they really represent an international group, and this is such a stimulating meeting. Congratulations to the organizers and to Luca. But the last 4 speakers were from the UK, US, Australia, and Japan, I think representative of kind of the work that's being done around the world, and is very encouraging. So as a clinician, I was especially taken by Toby Marr's talk about both the diagnosis and biomarkers, and how crude our markers have been to separate individual patients with interstitial disease one from the other. And I think that's an area that we clearly need to go with greater enthusiasm, and the molecular phenotyping to subset patients with IPF, as has been done with periostine for asthma, surely will happen, and that's a direction that many of you are working on, and I encourage greatly. I was also struck by using home spirometry. We've used home spirometry for lung transplant for 20 years, but I think this is a great application and a great idea, because many patients can reproduce vital capacity very predictably, and in lung transplant, I think it's an early marker of lung rejection. So this should be an even better application, and it's inexpensive. So it costs less. You can buy a machine for $100, I think, and at least in the U.S., lung function testing in the lab costs $500 or something like that with a technician and others. So it's readily expensive. In the U.S., many patients now buy an oximeter and measure their pulse in oximeter, and in an early stage, of course, saturations are of little or no value until they reach further stages where they desaturate with exercise. So having markers of early disease and progression may be a way to select for trials. I think that, as in the curves that Toby showed, in the individual patient, to select those who are experiencing subacute progression. So molecular phenotyping and other selective phenotyping. I really enjoyed Jeff Horowitz's talk about the fibroblast resistance, and clearly there's better and better basic understanding that's coming to play about apoptosis and the pivotal role of caspase-3, and as a clinician then the target for treatment-directed possibilities. As a clinician who's interested in the genetics of IPF and pulmonary hypertension, I was especially struck by Dr. Court's talk. I think the vasculature in IPF and other diseases has been way underemphasized, and as you can see, our tools are inadequate. We really need better measures of small microvascular disease in a variety of different lung diseases, pulmonary hypertension and in pulmonary fibrosis, and I think the Unimore device is an interesting one and looks promising, but I think maybe coupled with other new technology may be interesting and allow us to detect those patients that Jürgen Burr mentioned who have predominantly a pulmonary vascular phenotype as the basis for their disease, and possibly a treatment directive. And then in closing, Dr. Zuma's talk made me very interested to see the follow-up data. Surely follow-up studies are important, but it's made me recognize as a clinician, having treated patients really since 1980 with interstitial disease, we had a few decades of really wandering in the dark trying to treat IPF with agents that in retrospect we now know hurt patients instead of help them. So the worldwide multi-center trials that have grown up out of the original early 90s, or 1999 I guess was the first randomized multi-center trial, that really is encouraging to me, that to look at the new agents or new pathways that might be intervened upon, that now trials can be done, enroll quickly with really reliable data. So I think that we've made enormous progress in my lifetime and hope to see more. So shall we have some discussion?